Chapter 30, High-Risk Newborn, Acquired and Congenital Conditions. While reviewing this chapter, I really want you again to consider the role of the nurse during this, rather than that high focus on the acuity of what's going on with these newborns as well. Respiratory complications. When we think about respiratory complications in the newborn, we really want to think about how are they oxygenating? What else is going on? Is this a normal kind of transient tachypnea of the newborn as they acclimate to extrauterine life? Has there been another issue that has been ongoing, such as meconium aspiration? Is that what is causing respiratory issues in the newborn here? Or over a long period of time, does this newborn continue to exhibit characteristics of pulmonary hypertension in the newborn that is causing those respiratory complications? In slide 3 of 16, we have a nice visualization of that meconium and how the passage is in the normal fetus. Typically, the most amount of meconium aspiration happens in the intrauterine period. So there's meconium that has passed, there is that kind of gasping reflex in utero as the newborn continues to practice its breathing motions, which causes some of that very sticky tar-like substance to kind of come further into the lung tissue of the newborn. This can cause hypoxic fetal lung damage, thus causing impaired gas exchange, impaired pulmonary vasoconstriction, which can cause persistent pulmonary hypertension of the neonate. And that is all due to that meconium aspiration. Most likely, most of that occurs intrauterine, but also a good amount of meconium aspiration can occur in the moments post-birth, during that first breath, especially, of air, especially as that newborn kind of brings that air in and obstructs their airway. Hyperbilirubinemia, or the pathologic jaundice, which is the cause of additional red blood cells kind of binding to the liver there and causing jaundice. And therapeutic management for these babies would be that phototherapy or exchange transfusions. In slide 5 of 16, we can see a newborn under those billy lights, is what they're called. We see those blue lights coming from above, so we can help that and promote that liver digestion of those additional red blood cells and decrease the bilirubinemia of these newborns. We also want to keep a close eye on the eye protection of these newborns. So you can see that newborn is wearing what is kind of akin to a pair of sunglasses or some eye covering so that they don't have any damage to their very delicate kind of vessels and circulatory system to their eyes from these lights. So we just want to keep their eyes coated, and a little bit of that light process helps that body to kind of digest some of those additional red blood cells caused by the hyperbilirubinemia. In an assessment of these, we want to look at the color of the newborn. We want to assess for any kind of yellowing color. We want to assess the color of their sclera. We can also do a blood test for these ones and see what their bilirubin levels are. Nursing diagnoses, hyperbilirubinemia there. We worry about their ability to metabolize these additional red blood cells. We want to discuss the expected outcomes, talk about when the highest likelihood of that jaundice might appear, especially in those days preceding birth, about day 3, day 4 of birth, and how parents can kind of work with their newborns who are having this. Infection. Transmission of infection could happen during the intrapartum period. If mom especially has an infection during her labor and birth, we want to assess our newborn for sepsis. We want to perhaps get some laboratory values on them, perhaps start some prophylactic antibiotics. We want to talk about the therapeutic management of these babies who've been subjected to infection, especially during the labor and birth period. A very close eye on their vital signs. We also want to remember that with newborns, instead of exhibiting high temperatures, these newborns would likely show an instability in their ability to thermoregulate. So their temperatures might drop as a sign and symptom of their infection. We want to consider infants of the diabetic mother and the scope of the issues there. We know that babies who are born with moms who had diabetes during the pregnancy, especially in the first several days or for several hours after birth, might experience difficulty maintaining their own blood sugar level. In particular, if mom was a non-adherent diabetic, or if she had changes in her medication during her diabetes, or the additional added therapeutic management of diabetes. We want to assess these newborns for their ability to regulate their blood sugars on their own, and we start to worry when they have exhibited signs and symptoms of low blood sugars. We want to look for their irritability, we want to look for their jitteriness, assess their vital signs, and ways that we can kind of manage them would be feedings, especially if mom is breastfeeding. We want to encourage these babies to nurse as much as possible to help maintain those blood sugar levels there. We can see perhaps a large for gestational age infant there in slide 9 of 16. Polycythemia, hemoglobin levels greater than 22 and a hematocrit greater than 65. We want to review what some of the causes of polycythemia are and what its manifestations look like. Are these infants who might have kind of a risk for petechiae? What does their skin look like? What are some additional considerations we want to have for these newborns who have very high hematocrits there? And what are some nursing considerations in relation to those? Hypocalcemia, total serum calcium concentration of less than 7. Early onset, usually exhibited within the first 72 hours of birth, and a late onset would be about 1 week of age. Want to look at manifestations for babies who have low serum calciums in their blood. What would these infants be exhibiting? What are some causes of hypocalcemia? Is this something that is congenital? Is this something that is not congenital but needs to be monitored? And we want to also consider those nursing considerations in caring for patients who have the hypocalcemia. Prenatal drug exposure. We want to identify patients in the prenatal period who use drugs of abuse and or who perhaps use maybe some prescribed medication that will exhibit signs and symptoms of withdrawal for newborns. We want to identify those patients in that prenatal period so that we can prepare parents as well as review what the procedures are in monitoring newborns who are withdrawing from medication. Therapeutic management, each case is very specific. It also really depends on the type of medication that the newborn has been subjected to during labor and or the pregnancy itself. How are these newborns going to feed? What is their rest like? And bonding with parents, or bonding in general with perhaps hospital staff if the parent is not available to do so. These newborns tend to be very, very irritable, especially when withdrawing from medication. They tend to be very restless, so it's difficult and challenging to be able to kind of balance the bonding, rest, and the feeding as well. A newborn that's very irritable is going to have a hard time feeding, very kind of disorganized in their ability to get nutrition for themselves. PKU is a genetic disorder that causes central nervous system injury. This is a test that doesn't always show outward symptoms but does require immediate interventions. Typically, a test that is done in the newborn screening, usually performed by about 36 hours of life. This does require some medication, as I had discussed, so therapeutic management is important to kind of monitor there, especially for later in life. These are patients who might have a special diet, so it's important to kind of review that therapeutic management for newborns with PKU. Congenital cardiac defects, classifications. So there are different levels of cardiac defects. Depending on where the defect is itself can really kind of generate the kind of clinical manifestations that healthcare providers would be looking for. Are these cyanotic defects, left to right shunting, depending on what ventricles of the heart are involved? Is there a defect with the causing an obstruction in blood flow or decreased pulmonary blood flow? And if so, how are these newborns being oxygenated? Is this something that has good outcomes? Does this have poor outcomes? So it's really important that we review where that defect is and how it's going to impact these newborns. Clinical manifestations of congenital cardiac defects can include cyanosis, difficulty maintaining oxygen saturations on these babies, perhaps requiring additional or supportive measures from oxygenation. These newborns might have audible heart murmurs, tachycardia and tachypnea, or other signs and symptoms there that really kind of exhibit the fact that these newborns need have greater oxygen demands. So We want to review what the therapeutic managements are for each one of those cases and any kind of nursing considerations. So things that would be important for the nurse's role, such as nutrition for that newborn, maybe counseling that mom on supplemental feeding or finding ways to kind of work with both mom and baby.